So I'd like to talk to you about soft tissue around implants. Many times when we discuss about soft tissues, we're talking about aesthetics. But I like to take a little different tact because we have some cases, not necessarily in the aesthetic zone, where we see soft tissue deficiency. This is one of my cases, maybe for more than 15 years. And then when we look at the bone, we see also marginal bone loss on these cases. And the question we have to ask, what came first? Was there soft tissue deficiency that led to the bone loss? Or did the bone resorption lead to the soft tissue recession? So I believe that there's an interplay between the mucosa and the bone. And in the next hour, I'd like to explain about the scientific evidence that we have about the interplay between the mucosa and bone. So just to take a little step back, I'd like to just go over the basics of the anatomy of the mucosa around implant and compare and contrast that to gingiva, which we know a lot about. So when we're looking at the gingiva, you have periodontal ligament, you have connective tissue attachment, you have junctional epithelium, and a very well-established biological width. Around implant, we have similar type of structure in that we have bone, no periodontal ligament, we have connective tissue, perhaps different, and we have junctional epithelium. So this interface was described very well by Professor Lindy and Berglund, where they describe the nature of the attachment of the mucosa to implant. What they define are two zones. The zone that's right adjacent to the implant, that zone does not have any fibers. Around teeth, you have these fibers that insert into the root. You don't have anything in the root for the mucosa to attach to. So what you have are these cells, these fibroblasts that are just hugging the surface of the implant. That's all you have around the implant. You have these cells that are tightly kind of hugging the implant, but there's no insertion of fibers into the implant. And then it's only farther away where you have collagen fibers, you have blood vessels. So this has been suggested as part of the basis that maybe the attachment of the mucosa to implant is not as robust of that of teeth, and maybe that junction will be more susceptible to bacterial infiltration. So what is the nature of the tissue that we need and desire around implants? Should it be keratinized? Does it matter? We know around teeth, initially there was some suggestion that you have to have a minimum zone of keratinized gingiva, and then later it was discovered that as long as the inflammation is kept under control, teeth can be maintained very well healthy periodontium as long as the inflammation is under control with very little keratinized gingiva. What do we know around implants? There have been a number of studies of the keratinized gingiva and its significance around implants. And I describe one of them for you because this one has a little bit of a long-term follow-up of 5 years. So they divided the keratinized mucosa around implants into two groups. Those that were at least 2 millimeters or adequate, shown in blue. Those that were less than 2 millimeters, shown in red. And what you could see, the areas that had less than 2 millimeters of keratinized mucosa had more plaque accumulation. Why would that be? Well, we know from clinical experience that patients who have inadequate keratinized mucosa have sensitivity, maybe they don't brush as well in those areas, and they accumulate plaque. And also, the areas with inadequate keratinized mucosa have more inflammation, and they have more recession. So most of the studies that have been done in this area concur that the presence of a keratinized mucosa is associated with maintenance of health in terms of control of inflammation, plaque control, and stability and resistance to recession. And this was also demonstrated experimentally in the years past in a non-human primate model, in a monkey model, where the group of Professor Lindy excised and cut out all of the keratinized gingiva around the implants of monkeys, and what they discovered that these areas accumulate plaque and develop inflammation, whereas those areas where the keratinized mucosa is kept intact, those areas are maintained with lower amount of inflammation. Now, the group from Klaus Lang went a step further. They also placed implants in dog model with intact keratinized mucosa, and the experimental group, they completely cut out the keratinized mucosa and sutured the flaps. When they looked at these, they looked not only at the mucosa, they looked at the bone. And what they found is that wherever they cut out the keratinized mucosa, that group exhibited more bone loss. So you may think, well, maybe in the dog they had thin bone, and that's why they lost bone. But they also looked at the areas that had at least 2 millimeters of buccal bone, and they found out where the keratinized mucosa was cut out. Even when the bone was 2 millimeters in thickness, those areas exhibited more bone loss. So this suggests that effect of lack of keratinized mucosa around implants is not just on the mucosa. It's not just control of inflammation. It's not just prevention of recession. It also has an effect on bone. Where you don't have enough keratinized mucosa, those areas are more susceptible to marginal bone loss. And this is very direct evidence of that, showing the significance of keratinized mucosa around the implant. So we may be convinced that keratinized mucosa has this magical power that's going to maintain health around the implant. But before we come to that conclusion, let's think about it a little bit more. Keratinized mucosa is also very thick mucosa. So which aspect of it is more important? Is the surface keratinization important, or is the mucosal thickness more important? Well, Professor Lindy had done experimental study in that way, where they placed implants in dog, and these dogs had naturally about 4 millimeters of keratinized mucosa in thickness. So what they did was they kept the mucosa on the surface, the keratinization on the surface, and they thinned out the flap, so that in the experimental group, now they have very thin keratinized mucosa. And they compare these two groups. The test group had 2 millimeters of keratinized mucosa in thickness, and the experimental group had very thick mucosa, which was 4 millimeters. When they compared these two groups after 6 months, they found that the ones that had thick mucosa had very stable bone. Those that had thin mucosa, but still with keratinization on the surface, had marginal bone loss. Why would that be? Knowing what we know today about biologic width, we can now appreciate that where you have thick mucosa, it is possible to establish a biological width above the bone, supracrestally. Where the mucosa is thin, it's not possible to establish biologic width within that parameter. So what happens is that marginal bone loss occurs, so part of the biologic width continues subcrestally. So marginal bone loss has a way of establishing a thickened biotype. It thickens the biotype because it happens at the expense of bone. So that's why the thickness seems to matter more. So where you don't have enough thickness, the body creates thickness by resorbing bone. And this has been also demonstrated experimentally in patients. This is Thomas Lekenvikes, where they showed that in patients who had thin mucosa, they compared those to those patients who had thick mucosa. And then what they did, they took those patients who had a very thin mucosa, and they did soft tissue augmentation, but they did the augmentation with an allograft. The allograft was able to augment the mucosa and make it thicker without adding surface keratinization. They just simply increased the mucosal thickness. So what they looked at was the effect on the bone. So they compared these three groups in terms of their bone response. And what they demonstrated very clearly is that the group that had thin mucosa had a lot of bone loss. They had nearly 2 millimeters of bone loss. But the group that had naturally thick mucosa had very stable bone with very little bone loss, less than 0.5 millimeter. And the thin group, where they augmented the mucosa without making it keratinized, just by an allograft, that group also had a very stable margin of bone. So putting this together, along with Jan Linde's studies, it clearly demonstrates that it's not so much the surface keratinization that matters, because even if you keep the surface keratinization constant, if you increase the mucosal thickness, it leads to marginal bone stability. So mucosal thickness is what really matters because it allows the establishment of a stable biological width. I discovered that randomly in one of my patients, except I didn't recognize it at the time. This is one of my patients who presented. Unfortunately, I did not place these implants. These implants were placed by another colleague, and because of the angulation, they were really non-restorable. So we had to extract these implants or explant them, and the remaining teeth were also extracted because of the severity of the periodontitis. So we decided to place a full arch of implant. But at the time, I was so focused on bone. We were looking at the CBCTs, we were measuring the thickness of the bone, the height of the bone, looking at the distance of the bone to the inferior alveolar nerve to make sure that we have sufficient bone height and width. And where we didn't have enough bone, I augmented the sites. But then, when the case was restored, this is what we had. And everything seemed to be as it is routinely in these cases. And as you could see, the patient had very, very thin mucosa. But he came back after the therapy, and he kept complaining that the implants that you place hurt. So at first, I thought, well, maybe I was too close to the inferior alveolar nerve, so I took CBCTs and showed that there's adequate distance to the nerve, and it's not because of nerve impingement. So I was examining his mucosa, and the areas will bleed. So I said, well, let's go over the oral hygiene. Let me show you how to brush and floss these areas. And he was swearing that I spend 20 minutes a day brushing and flossing. As you can see, he has very good oral hygiene, but still he had some bleeding. So what I decided to do was the only thing that I knew what to do, which was to do soft tissue augmentation. And here you can see after 2 years, even the areas that he had clean, plaque-free presence, he was getting inflammation in those areas. Now I understand what the inflammation was coming from. Now I understand why there was bleeding in those areas, even when he didn't have a lot of plaque. And the reason is that he was undergoing marginal bone loss. He was going through marginal bone loss, so that his body will naturally thicken the biotype by causing marginal bone loss. So I performed a connective tissue graft. The connective tissue graft was placed using the VISTA technique that I'll describe to you in a couple of minutes, which means that the connective tissue graft was placed inside the tunnel subperiosteally, which means that between bone and periosteum. When the connective tissue graft is placed so deeply, it doesn't increase the surface keratinization. And as you can see here, from before and after, he had a lot of inflammation, and the inflammation was subsided after the soft tissue augmentation, even though the surface did not become keratinized. So just thickening the mucosa was helpful in reducing the inflammation and making those areas not bleed. So we did the same thing on the opposite side, and as you can see, the tissues look very healthy, despite the fact that there's not surface keratinization. So I think, my view, what is important is really not the surface keratinization, which is on the oral side. What we really should care about is what is attached on the implant side and whether or not that mucosal thickness is adequate to establish a very stable biological width. So by the same token, the areas that have thin mucosa also have typically shallow vestibule. In this study, when they compared the cases that had shallow vestibule to those that had deeper vestibule, the areas with deep vestibule had more stable bone, and this in the same patient, the areas that had shallow vestibule also exhibited more bone loss. So, in many cases, we may have to do vestibuloplasty, deepen the vestibule, and there are different techniques that have been described for vestibular depth increase. The classic way is to perform a free gingival graft, which increases the mucosal thickness, it increases keratinization, and deepens the vestibule. But that is invasive because it requires harvesting of tissue. So there have been studies which have compared that to using a mucosal or the collagen matrix instead of a autogenous tissue, and this particular study demonstrated that both the free gingival graft and the mucograft achieved the same amount of vestibular deepening and the same amount of keratinized mucosa around this implant. So it is possible to increase the vestibular depth in the absence of autogenous tissue. So I'll just show you a different technique for increasing the vestibular depth. This is one of my patients. I had placed the implant using a two-stage approach. The patient was wearing a denture during the healing process. Now we're doing partial thickness dissection to do the second stage and connect the healing abutments. So what we did was to push down the flap, the partial dissected flap, down to the vestibular depth and to keep it down. One of the challenges to keep this flap down is that there's nothing to anchor it to. So I was installing some screws, some fixation screws to try to keep the vestibular flap down, and then attaching to some of these screws some LPRF in order to speed up the healing and cover the periosteum that was exposed in this case. And using a series of fixation screws, we fixated the LPRF to the surface. And you can see that by increasing the depth and just keeping the margin of that loose mucosal flap down, using the fixation screws, we were able to push that tissue down. So this is a variation of a technique that was described years ago as a pushback technique by Henry Goldman, which was basically designed to increase the zone of keratinized gingiva around teeth. So here we're just trying to keep the mucosa down. And here, I'm using the sutures to adapt the LPRF, but in most of the future cases, I've done this without the addition of the sutures. So you see, we establish a zone that's just covered by LPRF. And you can see, after the fact, we gain a great deal of keratin, a band of keratinized mucosa that was thick and deepened the vestibule without harvesting any autogenous tissue. It's just a variation of other techniques of using collagen matrix. Now here, instead, we're using LPRF with the help of the fixation screws. So let's look at other techniques of soft tissue augmentation around implants. Now, there are techniques that can be used for augmentation of mucosa around implants, and they could either be a free gingival graft or a connective tissue graft. In this particular study done by Klaus Lang's group, they took a free gingival graft, and in some group, they kept the epithelium, and another group, they removed the epithelium and used it as a connective tissue graft. What they showed in this is that when they use a graft, whether the epithelium was kept intact or removed and placed under the flap, in either case, thickening the biotype in this way was associated with more marginal bone stability. So whether you use a free gingival graft or a connective tissue graft, both of them work by increasing the mucosal thickness, and they lead to more marginal bone stability. So there's no right or wrong. It's a personal choice. If you want to use a free gingival graft, it works. If you want to use a connective tissue graft, it works. So there are different techniques, and I'll take you through some of these techniques. The free gingival graft is a very classic technique. The problem is aesthetics. You never want to do it in the aesthetic zone. This is one of my patients who had this procedure done, and all I could see when she smiles, very attractive lady, all you see is that tire patch right in the front. So it's not a good idea for the aesthetic zone. But if it's a non-aesthetic zone, free gingival graft could be a very useful technique to increase the vestibular depth, increase the thickness of the mucosa, and increase the surface keratinization. It works very well, but the downside is that the color and the texture don't match the surrounding tissues. Then there are other techniques that have been utilized around teeth, and some people have adapted these around implants. There's a intrasulcular tunneling that's very frequently used around teeth. There's also the coronal advancement flap, and this has also been used around implants. And then there's a VISTA technique, which stands for vestibular incision subperiosteal tunnel access. So first, I'll describe how these techniques work around teeth, and then I will describe them around implants for you. So just to take you through the steps of what VISTA entails, VISTA means vestibular incision. So we make an incision in the vestibule, a vertical incision in the vestibule, and then from there, we make a subperiosteal tunnel. What I should say is that when we're working around teeth, a lot of time has to go into root preparation and cleaning the roots and reducing the root profile by the odontoplasty. The next step is subperiosteal tunneling. That is basically a full thickness dissection, except it's in a lateral direction, starting with that vertical incision in the vestibule. So we go laterally and also extending the subperiosteal tunneling underneath each papilla, so that we're lifting the whole mucoperiosteal complex away from underlying bone, coronally advancing the gingival margin, and then fixating the gingival margin of each tooth to each tooth in a very stable location. In this way, the surgeon controls the position of the gingival margin by fixating that to each tooth with a composite, with a flowable composite. Then you can use whatever graft material you like. You can use connective tissue graft. In this case, I use an allograft. And then basically closing the access, the patient comes in, and the sutures are kept in 3 weeks. And you can see that the tissue is fairly well healed by this period. And then you can see the healing. This is after 1 year, we have complete root coverage. And we can see that what is really very helpful in these cases is increasing the mucosal thickness. That's what we really look for. The primary goal is increasing the mucosal thickness. And because in this case, you don't elevate the papillae, you don't make any surface incision, it is very helpful to actually give you some bulk of the tissue. But before thinking that we can regenerate papillae, I want to show you more long-term results that the papilla growth doesn't always remain. This is after 3 years. You can see that the midfacial tissue level is very stable, but the interdental tissue, as long as there's not interdental bone underneath there to support it, is not always stable. There are some cases that are exception, but generally speaking, that's not something we want to commit to patient. So one of our former students, Dr. Shoko Sato, who is practicing here in Tokyo now, she did as her master thesis comparison of 3 different techniques, showing that Vista, when used for soft tissue augmentation and periodontal root coverage, was associated with the highest amount of root coverage compared to other techniques, and significantly higher amount of complete root coverage. So she's preparing now this manuscript for publication. Another one of our graduates, who is now in University of Zurich, he did as his master thesis project comparison of before and after of these using 3D imaging technologies to superimpose before and afters to find out some of the risk factors that help us get better periodontal root coverage than others. And what we found is that when you look at all the factors, the most important was root prominence. So the more prominent the root was, the less root coverage was achieved. So the same thing is true with implants. If an implant is placed more to the facial, you get more recession. If you place the implant more palatally, you have less soft tissue recession. The same is true with teeth. The more root prominence, the less successful is the root coverage. That's why in these cases we try to do odontoplasty to flatten the root profile. So what we do, if there's root prominence, we try to eliminate it by flatten the root, and we use the same technique around implants. If an implant or abutment is too bulky, we try to reduce it to try to create a straight path for the mucosa to move across. And what we gain, this is Dr. Seiko Min, who is also from Nihon University. He completed his work and is one of our faculty now. He looked at the stability of the soft tissue augmentation, and he found that when we do this Vista technique and we gain mucosal thickness, the mucosal thickness is very stable over time, and what we gain, we keep at least over this 2-year follow-up period. So can we use other material like xenograft? This is mucograft, using it with Vista. This is a patient who had a lot of recession on her teeth. So we use Vista in conjunction with mucograft, and you can see that we overcorrected, and then after 6 months, there's still some deficiencies, not 100% root coverage on the 2 incisors, but when we follow the patient over time, actually there seems to be what we call creeping attachment. The tissue actually continues to move down, and we have complete root coverage. So can we use some of these principles around implant? Well, this is one of my patients who had the deciduous teeth that needed to be replaced. Obviously, space is a big problem in this case, so she was advised that it's necessary to do orthodontic treatment first to try to create the optimum space, and she didn't want to go through ortho. So we went through with what the space we had, which was just enough space to place a single implant. An abutment was placed that was kind of narrow in stock. The implant was placed more on the lingual position and created the illusion of a papilla. But when the patient came back from the general practitioner who restored it with a definitive restoration with a zirconia abutment, they made a very thick abutment. So the same thing that we discussed with teeth, if they're prominent, more associated with recession, the same is true with implants. Because soon after, she experienced mucosal recession around the implant. And when we look at the design of the restoration, we could see that the abutment was very, very wide. So the more space in the transmucosal portion that's taken up by the restorative contour, the less space there is for the mucosa. So the ideal situation is to have kind of like a trumpet-shaped concavity of the contour so that the mucosa will be thicker in this area. So what I did for her was to use Vista in this case, vestibular incision, subperiosteal tunnel, and place a connective tissue graft. And the graft that you want to use for these type of cases come from the tuberosity because it gives you a nice bulk and the tissue is very, very stable in this case. So, just going to go through this here. Sorry. We can also use the Vista technique for soft tissue augmentation. That's not just necessarily only for mucosal thickening, but to improve the contour for aesthetics. This is a patient who had a congenitally missing lateral incisor, and the bone was adequate, but she had a concavity. So you could see that in this case, the abutment or the pontic was sitting on top of the tissue, which is very unaesthetic, making a vestibular incision, subperiosteal tunnel, taking a very small piece of connective tissue from the tuberosity and using a lasso technique to bring it in. You can see that you can really increase the mucosal contour by this technique, develop the ideal contour, and then in this case, the implant was placed later. Typically, we place the implant simultaneously with the soft tissue augmentation because of the logistics. We did it in 2 steps. So the benefit of Vista is that by making a vestibular incision, we don't have to make any surface incision in the papillae or the mucosal margin. So that way, the contour looks unaltered. Also, this is a case who needed bone augmentation. This is, I'm embarrassed to say that this is my case. I made the wrong incision design. You know, when you make an incision, you don't want to make incisions in the anterior area. So I used a block graft in conjunction with particulate, but the incisions were placed too close to this area in the wrong position, and afterwards, we had adequate bone, placed the implant, but when we had the provisionalization, we ended up with a cleft. And also the contour is not really ideal. So the way we can improve that is to try to use Vista, vestibular incision, subperiosteal tunnel. So what I'm doing now is I'm bringing this tuberosity connective tissue graft underneath the surface, bulking it up from underneath, and then once this is brought down, we can coronally advance the gingival margin where the cleft is there to try to cover the area of the cleft and get root coverage in that area. So you could see that by increasing the thickness from underneath, we can improve the contour of a case that had too much of irregularities and anesthetic. This is a patient who had implant placed in the wrong position. Implant was placed too apically and too far to the facial. The general practitioner who was going to restore it said, can you please take this implant out, do bone graft, and place it in the wrong place, because by the time I restore it, I'm going to end up with a very long restoration. And I could see his point, because ideally, you want to have this kind of a restorative contour. And then if you consider the ideal contour, there's a significant amount of deficiency around the implant and around the adjacent areas. So the further facially the implant is placed, the more the mucosa is receded. So what I try to use is the vista, again in this case, to try to create some bulk of the mucosa. So vestibular incision, I remove the healing abutment, place the cover screw, so we can bring the connective tissue in the area. The choice of connective tissue is very important. Where you want to create more bulk, you want to take the connective tissue from the tuberosity. Even if you have very little tissue from the tuberosity, you can actually use that tissue, and actually the tuberosity connective tissue graft tends to expand, doesn't shrink like the palate does. So for the tuberosity, we bring that in the area of the implant without the healing abutment, so we can bring it right over the shoulder of the implant. And then you can see that we create bulk of tissue on the shoulder of the implant. And now the job is to try to make sure that the CAD/CAM abutment is made in such a way that it's not too bulky, okay? And then you have very little restorative contour on the facial to try not to push the tissue out. I've done similar cases where the patient goes back to the restorative dentist and they put a big bulky abutment on it and pushes the tissue back up. So you have to make sure that we keep things to the palatal, the implant as well as the restorative and abutment. What about extraction? Dr. Baroni talked in detail about extraction and described the studies by Araujo that when you extract teeth, you lose a lot of bone. But what happens to the mucosa? We know what happens to the bone, but what happens to the mucosa has not been studied as much after extraction. So what we decided to do was also to take a more relevant model, which is a non-human primate model. So we've done this study with non-human primate to digitally examine the extraction socket, and we've published a number of papers in that as well as in clinical trials to study the surface contour of the tissue, what happens with extractions that are either just undergoing natural healing versus those that have rich preservation. You can see that where the tooth is extracted and rich preservation is not performed, you can see a big concavity in the tissue contour. And then the area that had rich preservation maintains a tissue contour much better. So the tissue contour is actually a more important component when it comes to aesthetics than the bone itself. But when we look at the underlying bone, where rich preservation was done, we have better contour of the bone. Where the rich preservation was not done, now we've lost the buccal bone and we have a dehiscence there. So we've studied that, and in terms of the tissue contour, with or without rich preservation, and what we find is that if we divide the extraction socket into different zones, the zone that is most at the crest, at the top, 3 millimeters, actually, during the healing process, that first 3 millimeter of the tissue, 90% of it resorbs during the healing process if we don't do any intervention. So what you see in red shows that 90% of the crestal 3 millimeters of the tissue resorbs. We're not talking about the bone. This is just a soft tissue contour. Now, if we do ridge preservation, we could actually preserve a significant amount of it, maybe up to 50% of that. And the zone that is 3 to 6 millimeter, not even just the crest, the second 3 millimeter zone, which is 3 to 6 millimeters away from the crest, that zone, also half of that volume is lost. So the resorption of the tissue is not limited just to the crest. It continues down to 6 millimeter. So that is significant, but with ridge preservation, we can preserve the contour at the crest and also further away from the crest. And this is very important. And I show you a technique of ridge preservation. We published these studies already with these devices for managing extraction socket called socket cap and cage. You can kind of see how we manage these extraction socket. This is an 80-year-old patient. We want to do minimally invasive procedure for her, extraction. So what I'm doing first is I'm trying to have a device to close this extraction socket using this, what we call socket cap. The sutures are placed to kind of fixate it in place first, but loosely the sutures are placed, so we're ready to close it afterwards. Then this is the cage. Because there's a buccal dehiscence, I put this device that's very rigid and is resorbable in the socket to keep that contour and prevent it from collapsing. Then the particulate graft, which is a xenograft, is placed, and the socket is closed. So this is very, very, minimally invasive procedure. Allowed the area to heal. Could we have placed the implant as Dr. Han showed earlier? Yes, that would have been also possible. In this case, the bone loss continued way beyond the apex. So did the ridge preservation, you can see we maintained a very nice contour, so we came back and placed the implant after the healing. And then you can see we have good tissue, we have good bone with this implant that was placed in this way. And we have the histology. This is from the non-human primate study. Without ridge preservation, you end up with a severe kind of a knife edge crest. With ridge preservation, you have much better contour. Can you do immediate implant placement and do soft tissue augmentation? Yes. We have to do risk assessment. And that's deciding how many things do we need to do to these patients. This is a patient who has all the risk factors, has very, very thin bone, has recession on the adjacent teeth, and the third risk factor is that he's a lawyer, okay? So we're gonna do everything that we can to avoid recession around the implant. So the first thing, having a very thin facial plate, we're gonna extract it with minimally invasive technique with whatever devices you want to use to avoid luxation. Then, in order to place the soft tissue graft and also monitor that facial plate to make sure we're away from it, we're using VISTA, vestibular incision, subperiosteal tunnel. That gives us access to the facial plate for soft tissue augmentation, also making sure that that periapical fenestration is repaired. The implant is placed more toward the palatal, and a connective tissue graft, in this case, from the tuberosity is placed. And the connective tissue, what we do, we harvest it and make a little sashimi with that, and just making sure that it's not too bulky, and place it inside the tunnel. This is just adds a couple of extra minutes. This is very fast and very efficient. So you see, we place the soft tissue graft. Also in the extraction socket, we graft it with the xenograft between the implant and the socket. And when we do the provisional restoration, we don't make it so bulky. We don't have to fill that embrasure on day one. You leave it open, you leave it under contour. The provisional should be under contour, and you see there's no incisions in the papillae, there's no incision in the mucosal margin, but we have access to those areas for grafting. You see, as it heals, tissue fills in that space. So you don't have to fill the space on day one. You see that the adjacent teeth have a lot of recession, but not the implant. The implant has stable tissue, and you see that over time, the tissue remains stable. What is also important in the horizontal direction, we have stability because the soft tissue augmentation kind of compensates for some of that horizontal shrinkage that takes place. And we look at the CBCT showing we also have very stable bone. So we have to think in terms of not just about bone preservation. We have to think in terms of managing sockets. We have to manage the bone and the shrinkage that takes place by ridge preservation, but we also have to do tissue preservation by preventing tissue collapse, which could have aesthetic and functional consequences. So, in summary, we talked about some of the areas that are causing risk in our implant therapy. These include having very thin mucosa or having tissue that has no keratinized mucosa or is very thin. What do we do in these cases? I think if it's in the aesthetic zone, VISTA is a technique that may help you in introducing the soft tissue augmentation without lifting the papillae or making incisions around the margin of the tissues. And you can use allograft, you can use CTG. In the non-aesthetic zone, increasing the mucosal thickness is important. So if you want to use a free gingival graft, if it's in a non-aesthetic zone, please, by all means, go ahead. It's not my preferred technique. I prefer connective tissue graft, but if you like free gingival graft, it's a very efficient technique. You can also use allograft. You don't have to necessarily use a keratinized graft. In cases of shallow vestibule, you can perform vestibuloplasty using a free gingival graft or using a xenograft or using LPRF as described. Around tooth extraction, you want to preserve the bone, you want to preserve the mucosa. Ridge preservation is not just about bone preservation, it's also about soft tissue preservation. And if you already had areas that had extraction without preservation, have soft tissue deficiencies, if it's minor, you can use VISTA, connective tissue graft, allograft. There are also more advanced techniques with vascularized pedicle type of grafts that we don't have enough time to get into, but they give you even more bulk of tissue. With that, I just want to urge you that as you evaluate implant sites, we all have been trained to evaluate bone. Everyone takes a CBCT, everyone does 3D imaging, but now I just suggest to you that in addition to evaluating the bone, evaluate the mucosa for its adequacy to undergo bone implant placement. If necessary, include that in your initial plan, avoiding the problem. With that, it's been a great pleasure and honor for me to share this information with you. Thank you for staying this late.